Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today I am speaking with Christine Grella, Senior Research Scientist with the Lighthouse Institute. Chris joins me today from her office and home in Los Angeles, California. Hey, Chris.
Hello. Happy to
Thanks
be
so,
here.
yes, thanks so much for taking the time. We had a conversation to prepare for this last week, and you mentioned you started your career low about 30 years ago in
That's right.
substance use research under a highly influential mentor at UCLA.
Right.
So the question I need to ask is how did that early experience shape the way you approach your work today? And who is this mystery
Hmm.
influential mentor?
Well, my early work at UCLA has had a profound effect on my entire career, and I'm very grateful to the person who hired me, whose name was Doug Anglin. That was in 1992. Doug was very well known in the field. He was an early pioneer in studying the effects of public drug treatment, which at that time were quite limited. And he was a very good methodologist and could and had used a technique called natural experiments. So you could compare, for instance, the rates of crime and then the introduction of a treatment program and then the rates of crime after that. So looking at these global effects before and after the introduction of a treatment intervention. So it's hard to think back to that era. It was quite different. At
Sure.
that time, we were talking largely about heroin. There was not a lot of, as I said, public treatment. And Doug's group at UCLA, which I was delighted to join, they had a fabulous reputation for leading the field and doing what was called natural history research, which is really modeled on the medical model of natural history to look at the course of a disease over time. What is the onset, the progression, remission? And this really hadn't been done very much. There had been some early qualitative studies that were very in-depth case studies of people that had been followed. But in the particular study that I joined and started working on, it was based on the first public treatment that was available in California, which was a what was called the California Civil Addict Program. And it was a program for men who had been incarcerated, who had been arrested rather, for narcotics related crime. And they were mandated to go into a treatment program, which would then, if they completed, allow for their charge to be dropped. So this program was started in the mid 1960s, and the UCLA group had done a 10-year follow up study in the 70s, a second 10-year follow-up study in the 80s, and then when I joined, it was the third wave, and that became what we called our 33-year follow-up study, which was quite pivotal because the question was, what happens to these people over their lifetimes? How do they survive? So the first thing we see is the extremely high mortality rate of people with, at the time, heroin use disorders. And again, these were all men. They were drawn from a criminal justice setting, so they're not generalizable to the whole population, but we could see the effects of heroin disorders over a lifetime. And in that third wave in the 1990s, it was so interesting to see the way people's lives had diverged. There was a group of people who had ceased their heroin use, gone on and lived, upstanding lives in their communities, and nobody really knew they'd had a background in heroin addiction. And it would probably be shocking to their neighbors. And I think this is fascinating. We judge people on the basis of substance use disorders, and I think people would be amazed at the range of individuals who they may not know have had a substance use problem because of the huge shame and stigma associated with it.
Sure. Sure.
There were another group of people that went in and out of treatment repeatedly over years. They used frequently during periods when they were off treatment. And then there was a group of people that was they were in methadone treatment. Methadone was, again, the only treatment at the time for heroin addiction. That's different now. We have buprenorphine and other treatments. And they had stabilized on this treatment and they were working and participating in society. So we were able to develop this understanding of these diverse pathways over the
Mm.
lifespan. And the effect on me was to really always put into context that when we're evaluating people who go into drug treatment, which is mostly what I do, I look at people, how do they get into treatment? What factors enable them to get into treatment? What happens when they're in treatment? How long do they stay? And then what happens when they get out? But treatment is based on an episode, and it's usually a very small part of a person's entire life. So it helped me to understand that it's not just treatment that's important in terms of thinking about substance use disorders, but the entire context of a person's life.
So let me ask you something before we move on from that. You say it's based on an episode. Is it like an epiphany? It's something traumatic? I mean, what do you mean by that?
By that, I mean a lot of what we emphasize in our field is helping people get into substance use treatment. There's a lot of barriers to getting into substance use treatment. You don't know where to go, you don't know how to pay for it, you don't have transportation, you don't have childcare. And then there's motivational issues. I don't need treatment. I can do it on my own. What will people think? And we focus on getting people into the treatment episode. Well, that can last 30, 60, 90 days, maybe 180 days, and then you're out. And a lot of the criticism has been, well, if you think of substance use disorders as chronic disorders.
Oh, I'm sorry, Christy. I just to clarify because some of our audience are not specialized in this, and some of it's kind of new. So you're talking about treatment as an episode, not an
Correct.
episode that leads to seeking treatment.
Correct. That
Okay.
we have a model of treatment as episodic.
Mhm.
And when I was able to look at that over the lifespan through this longitudinal study that spanned 30 years, people were in and out of treatment episodes over time. But that maybe wasn't the most pivotal thing that was happening in their lives in terms of their substance use. So we focus as treatment researchers, I'm a treatment researcher on what happens in treatment, what do they get, what happens when they get out. And I, through my early work in this longitudinal study, really understood you have to look at the broader context of people's lives and how that changes over time. And a develop
Is this what we refer to as social determinants of health?
Some of it is in terms of their environmental circumstances, but it's also developmental. It's very different for people in their teens and their 20s and their midlife and later life. As part of this longitudinal study, we were studying older people. And so they had a lot of health problems, a lot of chronic health problems. And that was also where I developed an interest in gender differences in the lifespan and the longitudinal course of substance use disorders, because in that original study, which was done with an all male sample, there was a second study that I led, which was from people who'd been in methadone treatment in their communities. And we followed them up after 25 years and looked at how they were doing. And that was a study of both men and women, again in California. And the women were much more severe. They were much sicker. They had, and by that I mean physical health problems, chronic physical health problems, mental health problems. And so the question was, well, why do these women look so much worse? They all were sampled because they were in treatment for heroin dependence. In this sample, it was in the 1970s. Again, we followed them up 25 years later. So we started exploring things like what had happened to these women in terms of their family relationships. And of course, the issue of trauma became very prominent in substance use treatment around, 1990s, 2000, with the understanding that so many of the women that presented to treatment with substance use disorders had had traumatic histories. Men, of course, as well, but the rates were so much higher for
Mm.
women: sexual trauma, childhood and adult trauma, interpersonal violence, and the burden, what we call the burden of disease, which is an epidemiological construct, which is how the disease impacts any disease impacts a portion of the population. So if we look at the
Mm.
burden of disease of substance use disorders and we quantify that by disability adjusted life years, quality of life indicators, mortality indices. So you can look at the loss of life or the loss of healthy, functioning life. that burden of disease was much greater for the women in our study. So again, starting
Interesting.
to look at some of those contextual
Interesting.
features
Right.
for those that might explain those differences.
Right. So it seems that first phase of your research work was focused on incarcerated men, and
Correct.
it seems a lot of your work since is focused on women with substance abuse disorder issues. Yes?
Correct. Right.
Okay. Yeah, again, in our conversation, you said so many fascinating things, and somebody who's not immersed in the field, such as myself, they struck me as kind of counterintuitive. So I kind of want to go through that. It's a lot of fascinating stuff. So in our discussion, you noted that women historically, and you sort of begin to discuss this, historically face more stigma around substance use. Why so? One could perhaps intuit some of those reasons, but I'd like for you to unpack that a little bit.
Yeah, I think it's a really interesting topic because again, when we look back to the early studies from the 70s, the 80s, the 90s, the early field of substance use research, women were often the minority of any study sample. They were often not sampled if the study was taking place in a clinic, a treatment clinic. Women were not well represented in treatment. And we began to think, well, are women not going to treatment, or are they seeking treatment in proportion to the range of substance use disorders in the population? So we started doing a lot of research looking at treatment seeking and help seeking, because women, as we know, generally in terms of health services, do seek treatment more often from healthcare providers. But not so with substance use disorders. And of course, the underlying reasons have to do with traditional gender roles, where substance use is much more highly stigmatized among women and girls. Of course, again, it's stigmatized generally, but the burden of stigma is much greater among women because I hate to use this term, this sociological construct but it's very useful, which is the notion of deviancy. For girls and women, substance use was traditionally much more deviant. It was much more reckless, much more risk taking, associated with sexual risk taking. If a woman is a mother, the stigma attached to mothers with substance use disorders is enormous. You can think back to the era when crack was predominant and the whole concern around crack babies, which became very sensationalized, and the research really didn't bear out the level of sensationalization at that time. Subsequently, we saw similar concerns around meth babies with methamphetamine use. So women face a much greater burden of shame, which becomes
Mm,
a barrier to help seeking. So they weren't being
sure.
treated to the same degree of their need in the centers that we were studying. And the challenges, particularly related to child rearing, economic challenges were much more profound because women would typically come into treatment, for instance, with less education and employment history. So you have to really start from how do you rebuild a life. And one of the big challenges for women coming into treatment, for instance, was their relationship, because often the substance use was part of the relationship dynamic.
Ah,
Less so for men who, I mean, it could be true for men, of course, but men were often using with peers. But for women, it was often embedded in their romantic relationship or their marital relationship. And so it could be threatening to a woman to go into treatment. We still see that today, actually, that the relationship dynamics can often be a barrier for women seeking help, even though they may have a greater propensity in general, but substance use tends to be a little different in that regard.
it's interesting. You an Amy Winehouse fan?
Sure.
It's kind of interesting that her life, it very much parallels what you're talking
Mm.
about with her significant other, and it was just a really toxic relationship. And obviously, she spiraled. And
And her tragic death due to overdose. Yeah.
yes, yes,
Despite her
yes.
tremendous talent and, success. And I think I'll take that back to this issue of the life course perspective. She'd been in and out of treatment many times.
Yeah.
And why? Why is, it's such a hard thing for people to understand. That's why we introduced the notion of addiction as a chronic disease. Now, the disease concept has some challenges. A lot of people don't want to be associated with the notion of a disease. Other people embrace the construct, but it means different things. But what it conveys is this is not, again, the episodic, you're in and out of treatment, you're cured, you're done. It's a long-term chronic condition that requires management over time, which can be through mutual help group, 12-step, strong
Mm.
supportive networks we know is critical. And that's often, again, what we noticed in our gender difference research was often for women, they were shunned and shamed from their families and alienated from their families. They didn't have anything to do with
Yeah.
it. Wasn't so much true for the men. One of the interesting things we noticed in our longitudinal 30-year follow-up study is how many of the men who were in their 50s were living with their mothers. Their mothers still took care of them. They didn't maybe have bills, but they
Right.
could always go back to mom.
Yeah.
Many of the
Yeah.
women, that wasn't the case.
Yeah, no, that's interesting. Of course, I mentioned Amy Winehouse because she had that relationship with her
Yeah.
significant other, and their drug or substance
Mm,
use was sort of so commingled, so embedded in that
yes,
relationship. She was trapped.
exactly. Exactly right. The commingle is exactly the term. It's often the challenge. And then if you mix that with interpersonal violence. And so this is where we began to understand this greater burden of disease that I was talking about. It's not just the substance use, it's the being ensnared in a relationship where there's interpersonal violence, there's child, there might be child rearing issues. You may have lost a child to child welfare services, and that compounds the shame. So it became very apparent to us that both from the longitudinal perspective and then within our
Yeah.
treatment evaluation studies, that gender was a critical variable to pay
Yeah,
attention.
all the stuff that you're talking about seems to be so embedded in our culture and in just relationships and
Correct.
the dynamics. So it begs the question, has the stigma that has historically attached to women and substance use diminished at all? Is it the same? Where are
Yes.
we with this?
It's really interesting because, as we know, I was talking about, back in the 70s, the 80s, the 90s, society has changed profoundly around gender roles. And we have seen a diminishment of traditional gender roles with women in the workforce, even educationally, more successful in many ways, higher rates of admission to colleges and professional schools than men. But what's ironic is that as we've diminished the traditional gender differences, that's brought about greater parity in terms of substance use disorders. So while there might have been some protective effect that it was again more deviant to engage in substance, drug use experimentation and then developing a disorder, now those protective guardrails to some extent have been reduced with the parity around gender roles. And we're actually seeing now among young girls and adolescents earlier ages of initiation of substance use. It was the reverse before.
I exactly wanted to ask you that because that actually, to me, I don't want to overstate this, was a bit shocking when
Mhm.
you told me that girls, young girls, are now initiating substance use earlier than boys. What accounts for that?
Yeah, well, some of it has to do again with the developmental aspects that they mature faster and the onset of puberty is earlier. And onset of puberty leads young people into more social differentiation from their family and more socializing. And girls may be socializing with older peers because, again, they're maturing faster,
Mm,
where they're introduced to the opportunity. We know with young people, a lot of it is about opportunity to try and use and experiment in the norms of your peer group. So we have seen greater earlier ages of initiation and then greater severity when if a girl progresses. Again, a lot of young people are experimenting. That doesn't mean they all develop substance use disorders, but among those who progress, and if they wind up going into a treatment program, the girls tend to enter with more severity as well. So some of that, again, could be related to some of the trauma issues of that girls are experiencing around interpersonal violence and abuse. And I think some of the challenges of society as a whole are just are quite, for instance, we see eating disorders are highly associated with substance use disorders, and those tend to be more frequent among girls. So some of those social, cultural issues, I think, are affecting girls in that way.
Yeah. So what are the implications, or what implications does this trend have for prevention efforts?
Well, that's a really good question because I think, our prevention efforts at times have been pretty uniform. So when I would teach classes in substance use, I would always ask the students, tell me what you learned about, drug use in your high school because it's mandated, of course, it's required. And, it's always kind of a joke, it's seen as, oh, yeah, we had to sit through that and it wasn't very effective. And we know a lot about what's effective in terms of who delivers the message, the old DARE model, which was delivered by a police officer, get tough on drugs, didn't work at all because these were not people that the youth could identify with. So having a young person deliver the message is more relatable to young people. I will say I need to contextualize this issue of prevention within the current opioid crisis. So, if we move ahead to the present day, the opioid crisis is very different, for instance, than the one that I was studying initially with people that we recruited from, the 1960s, 70s, and 80s. What we see now is this widespread proliferation of opioids, not just heroin, which was really the singular substance earlier. Now we have prescription opioids, painkillers, we have the synthetic opioids with fentanyl. And these have proliferated among younger people. They're easy to transport. You can go to a party, there can be pills available. Unfortunately, people may not know what's in them. So the prevention interventions really have to target young people who are vulnerable in social situations. They may not have a disease, but they may be socializing in their peer groups where they're exposed to highly lethal substances. And that's incredibly different. And we saw that with the acceleration of opioid overdose deaths in the general population beginning around 2010 or so, with the proliferation of prescription meds that were being diverted and circulating around among the population, but particularly younger people overdosing, that those rates have skyrocketed as well. So our prevention strategies have to be about the risk, the high risk that's involved here, and experimentation, that you don't know what's in the drug supply. And this gets us into the issue of, harm reduction. If that's a very controversial issue, whether kids should be taught, how to test their substance for fentanyl toxicity, for instance. But the issue is it's a very different world, and it's a much more dangerous world in terms of the proliferation of multiple substances that are easily available to young people. That early heroin epidemic I talked about, it was highly segregated. It was, urban areas. It wasn't across the population as broadly. Our current opioid crisis cuts across all elements of the population, rural, urban, all social classes, gender, race, ethnicity. So the exposure to high risk substances is so much greater in the population, which
Is
underlies.
it is the reason for that just the easy access? Is it
Yes,
that simple?
the proliferation. So if you think about the heroin crisis, I mean, heroin at the time was being, grown overseas. It was being transported through Europe, down through Canada. Now we have all
But
these.
it was also controlled largely by organized crime, and they were
Exactly.
pinpointing
And we have,
areas that were
right,
highly vulnerable, susceptible.
right,
So I'm sure there
right.
was that
It
too.
was a highly controlled administration system,
Right.
or supply system, I should say. What we have now is, well, we have heroin coming up through the border, coming all different ways, but we also have pills that are being manufactured and diverted. And again, there's been attempts to tamp down on that through prescription monitoring programs and tightening up the prescribing policies, but there's still a proliferation of painkillers and medications. I mean, that, as I mentioned, when I would talk to my students about this, I would ask them, well, how many of you, when you got your wisdom teeth removed, were sent home with, a dozen Percocet?
Right.
That That used to be the standard. And of course, maybe they would take one or two and the rest would be in the medicine cabinet. Well, the kids had easy access to this. And so we had such access through supply. But then when we started seeing the adulteration of the substances in the drug supply, so it wasn't just a painkiller. It could be combined with other things, or it wasn't just a sedative. For instance, you may think you're taking a benzodiazepine, but it's been adulterated with a synthetic opioid. Now it's really toxic because you don't have any habituation to the opioid and you think you're taking another substance.
Mm,
So back to your question on prevention, we have to be much more tailored, much more forthright about the risks, really giving that information. It's not just we want, one puff and your life is ruined, which was the old scare tactic, but let's be honest about the circumstances here. And so many kids actually have in their peer group friends who've overdosed. That's not uncommon anymore. So those messages are really important, but they have to be credible. And that's where I think we've done a better job of tailoring the messages to the circumstances today.
yeah, you think, yeah, one group is going to require a different type and different delivery of those messages than another group. It's also interesting. I recently did a podcast with Dr. John Kelly from Harvard, and we talked
Uh-huh.
about the war on drugs and what a misnomer it is simply referring or using war metaphorically and in ways not so metaphorically. And we talked about the benefits of bifurcating the problem into a demand and supply side. I think in our
Right.
politics, we're so often focused on the demand side, on the supply side rather than the demand side, which is kind of what we're
That's
talking about.
That's exactly right. We have put, if you look at the federal budget, the drug control budget, which is the best way to understand the current drug policy, and you look at what proportion went into supply reduction, traditionally that was about two-thirds, and a third demand reduction. Now that got equalized in the past few years. Definitely so much money was put into demand reduction because the opioid crisis became so visible and predominant, again, with people in their communities and neighborhoods seeing the ravages of opioid overdose. So that got equalized a little bit with more money going into demand reduction. Maintenance,
Yeah.
what we mean by that is treatment and prevention.
Okay, I'm going to give you an opportunity to get a little bit outside, perhaps your comfort zone, perhaps get on a little bit of a soapbox. But although you're primarily a researcher, what kinds of partnerships or pathways you think are most promising for translating your research into real world change? I know that's a huge question. If you had the answer, we'd probably be a little bit further along, but I'm going to throw down the gauntlet and ask you that anyway.
Well, when I started my career, I'll circle back to where we began talking. One of the first studies I worked on, in addition to the longitudinal study I described, was a evaluation of a methadone program, particularly related to HIV risk reduction, because HIV had been identified as injection drug use had been identified as a conduit of HIV infection. And although I worked at UCLA, my office was in the methadone clinic, and it was tough. It was a tough environment. There was a lot of crime. Again, the segregation of drug treatment into, out of the way neighborhoods, not in the mainstream, which really characterized that era. But it was one of the best things I did because I was in the clinic. I wasn't the researcher, in the ivory tower doing the research. I was in the clinic working with the clinicians, really understanding the people who were coming in for treatment. And that partnership was so critical. Now there's a well developed field of research that's called community based participatory research. So our original models were, again, the researcher designs the study, at the academic institution, and then maybe they go to the community and ask, will you be a partner with me? Now we really understand, well, the best way to move our knowledge that we're generating from the research is to be partners from the start and bring in our partners and together develop our methods, our study questions, and our process together so that there's really partnerships between the researchers and, in this case, clinicians in the community. or community providers because we are essential to each other. The community partners really want the knowledge. They want to improve their treatment. They want to make their evidence-based treatment the best that it can be. There's no
Yeah.
question, anytime I've gone to a treatment program, people are so dedicated to what they're doing. It's not easy work. So they really want what they can learn from researchers and vice versa. To do our work, it's critical that we have the partnership with the community providers and really understand the community.
Yeah.
And that's been the most enjoyable part of my work, really, is working closely with communities, community providers, and learning from them and being able to give back. There are lots of mechanisms now for how to move treatments that we develop evidence for, how to move those into community settings. I think there's so many challenges now, though, and you mentioned the social determinants of health earlier, and the issues that when people come into treatment now, again, my focus is drug treatment, they're not just dealing with a substance use problem, they're dealing with a housing problem. They're dealing with an access to healthcare problem. They're dealing with economic problems. In our current study, where we're testing an intervention to link people coming out of jail into treatment for opioid use disorders, I started noticing when I would listen to the recordings of the intervention sessions, how many people would talk about, well, I can't go to treatment because I'm caring for my aunt, and I can't go to treatment, I've got, my son or whatever. And that caregiving responsibilities, we don't have a society that provides a safety net for a lot of people in terms of income or home, health care, child rearing, and that safety net is being challenged right now as well. So when people come into substance use treatment, we're dealing with a whole range of issues that are so complex. So the
Yeah.
best way, I think, is to think about how we can engage our treatment community with a broader community perspective to help people who, what I see now, are coming in with much more severe challenges to just sustaining a stable life. And
Yeah.
the substance use is just one problem out of many.
Yeah. It's interesting. We started this conversation before we hit the record button. We were talking about the tsunami
Yeah.
and its effects in Japan,
Hmm.
Alaska, I believe Hawaii even, and of course the coast of California. And then we talked about how you guys are living on borrowed time. You're on the San Andreas Fault, and there are other faults there. And it feels like we talk about this issue, we talk about social determinants of health. That fault line is the growing inequities in our society. So it's becoming more precarious and more difficult, and I would imagine exacerbating these problems. Yes?
There's no question. I think that's, again, if I reflect back, because I've been doing this work for, again, over 30 years, it was never easy.
Yeah.
And people who had heroin use problems in 1980s and 90s, they were certainly dealing with economic problems, but for many of them were able to, work and, skilled or unskilled labor jobs and had access to resources, housing resources. Now it's those challenges are so much more significant. And I do think it really means that as in the substance use field, we have to think in terms of, again, broader community issues and equity issues, because that's our population that comes in and is seeking treatment. And our goal in our studies is to find ways to help people get into treatment, make
Mhm.
it easier for them to get in and stay in treatment and get help that they need. It's requires us to think much more broadly about what can we do in this, should we be forming coalitions with food providers and housing providers, and how do we build a more comprehensive network? And I know that's what all communities are struggling with
Mhm.
right now.
What's also interesting is that, these conversations I've been having with your colleagues, that it's very much of a piece with what they're doing, which is to say, the researchers are working hand in glove with the people in the field, implementing these programs, but they're not implementing them in a vacuum. They're bringing in other stakeholders in the community, law enforcement, small
Right,
business,
right, right.
government agencies, and so forth. So it's not working in these isolated, or as you
Correct.
refer to, these ivory towers. So it
Right.
really is almost like the ethos at Chestnut and Lighthouse to do
Right.
that very thing.
Right. I think that's really true. And I think one of the things that has changed, again, as I reflect back, and we talked about stigma earlier on, is ironically, I mean, substance use, having a substance use problem is still stigmatized. It's not something that people like to
Sure,
share.
of course.
But because substance use problems have become so much more visible in our society, again, with the opioid overdose crisis, there have been many sensationalized overdoses that have occurred. And everybody is very aware now, so much more aware of the substance use problem that confronts our society. In some ways, it has, I don't want to say lessen the stigma, but it's made it more commonplace for people to understand when we talk about addiction as a chronic disease or chronic disorder, the challenges that people face, and perhaps to be more sympathetic and supportive of public policies. We've seen that, increasing support for public policies that support that demand side. I'm sorry, the demand, the treatment reduction side, that we've seen a greater understanding in the population at large when we look at public opinion surveys, for instance.
Right.
Because in the past, it was really incarceration was our strategy, which is why that early study I talked about in California was one of the first attempts to do something a little bit different than just incarcerate, but provide a treatment component. And so we've moved away from just lock people up, understanding that's not very helpful. It's not good for society to have people locked up for years when treatment could help them return to their families and be productive in their communities. So I think we have a greater understanding of substance use disorders. We have a greater acceptance of the need for society to provide supportive resources. And for healthcare systems, that's been the other big change, is moving
Mm.
drug treatment from these isolated, highly stigmatized clinics and moving drug treatment into the primary healthcare system so that your doctor now, when you go into a checkup, you'll answer a bunch of questions about your health status. You'll be asked how many drinks you have a week and whether you use illegal drugs. Now, whether people answer honestly is another issue, but the point is it opens up an opportunity for
Mm.
discussion with doctors who in the past did not want to talk about these issues and deal with them.
Yeah.
Nobody wanted to treat patients who had drug problems because they
Yeah.
were to treat.
Yeah. Well, Chris, thank you so much for ending this on a hopeful note, a hopeful gloss on what otherwise seems, let's face it, a pretty intractable problem.
Yeah, I think as a society we have to understand that the proliferation of substances will always be with us. We didn't talk about alcohol, but alcohol is our number one drug of abuse. The manufacturing of medications that have abuse potential. So rather than think about, well, how are we going to get rid of this problem altogether? It's like, how are we going to manage this public health issue the way we manage other public health issues and not just relegate it to a segregated sphere of treatment, but really bring it into the public health mainstream. And I think we've made a lot of progress in promoting the public health model of treatment for substance use disorders.
Yes, and thanks in no small part to your work, the work of your colleagues at Lighthouse and Chestnut. Chris, this is a fascinating, great conversation. Thanks so much.
Well, thank you so much, Charles. I really enjoyed it.
Same. Today, I spoke with Christine Grella, Senior Research Scientist with Lighthouse Institute. She joined me today from her office and home in Los Angeles, California. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.